about the meeting. Let me see if I can do this. That should be coming through okay. Is that right, Grace?
Yes, perfect.
Okay, so it's a 4.5-day meeting. There's 22 tracks. There's something for everybody, as you could see here. We probably have the strongest nursing track and international track at a World Congress that I've seen. I'm glad Dr. Novick is on the line. There's going to be a lot of work with the NGOs and all the great work that he's done around the world. And we're really glad to have him as part of this. I'm just going to show you just a couple of very quick videos. See if this comes through. You hear the sound, Grace?
Yes, perfect, you.
Okay. It's that handsome guy in the upper left. Look at that. Sorry about that. I know that, thanks for taking a few minutes to watch that. We're very excited. We've been working on this for 13 years. I can't believe it's a year away. A lot of people have helped out. There's a number of questions. I know we have a large international audience today about visas and other things. I'm happy to take any answers in the Q&A or in the chat box. And my email I'll put out there if anybody needs it, and we can talk about that moving forward. Grace, do you have the QR code? You're muted, I think. There we go. So if you want to scan that or you can just go to our website, WCPCCS, World Congress Pediatric Cardiology, Cardiac Surgery 2023.org, and sign up for updates. Grace, thanks for giving me a few minutes at the beginning. I'm really excited for this paper. So let's proceed with the introductions, okay?
Okay, so guys, if you want to scan the QR code, it is going to lead you direct to the website of the World Congress, and please subscribe for the newsletter. And then you're going to help us to know more about you, more about the audience we're going to expect. And for sure, it's going to make you be aware of all the news that we're going to send you by email. And on the website as well, we have all the links for the social media. Please follow us on the social media of the World Congress. This is going to be an amazing meeting. Please save the date and join us there. So today we are very happy to discuss this paper. Dr. Sharmil is going to start to introduce the paper, and then we are going to have Dr. Novik, that is one of the authors. Sorry. That is one of the authors that is going to discuss with us the important points of this paper, and then we're going to open with this amazing panel full of specialists with worldwide experience to discuss this very interesting topic. So Sharmil is with you. Thank you guys for attending today, and thank you very much for all the panelists.
Grace, am I starting?
No, he's starting to set. He's going to highlight, summarize the paper, and then you go.
Okay. Right.
Thanks, Sharmil.
Right. Very good evening to all of you. I'm Dr. Sharmil. I'm a fifth-year resident of cardiothoracic surgery from Sir Gangaram Hospital, New Delhi. Over the next 15 minutes or so, what I'm going to do is I'm going to summarize this paper. I'll introduce the paper first, go along and summarize the methods of the paper, and then summarize the results of the paper. I will conclude with the conclusions drawn by the authors, and finish my presentation with by listing the limitations that have been in the paper. I'm not going to go through the discussion part. I believe that is what we are here for, and so that part is going to be, I think, an open discussion. So without wasting further time, I would like to go ahead. VSD is the most common congenital heart defect that we come across in our clinical practice. The stages of the presentation, however, they do differ in the upper income countries as compared to the lower and middle income countries. It is believed that in the upper income countries, the children present in the infancy, and they usually undergo a very low risk correction during the infancy itself. While in the lower and middle income countries, the children frequently present for the surgery at an older age, usually with an elevated pulmonary vascular resistance and pulmonary arterial hypertension. Therefore, post-operative pulmonary hypertensive crisis as a cause of death is one of the problems in these patients. And the two major things which can control this pulmonary hypertensive crisis is drugs, the drugs targeted at the pulmonary vascular bed, and ECMO rescue therapy, both of which are prohibitively both of which are of prohibitively high cost in most of the lower and middle income countries. Therefore, to mitigate this risk, a new technique was introduced in 95, I believe, and it was described well in 2005 by Dr. Novik himself, where he started using unidirectional flow VSD patch to mitigate the risk of the post-operative pulmonary hypertensive crisis, to reduce the mortality after surgery in these patients. So this paper is a retrospective single institute non-randomized study which started in so the starting period was from 5th of from the May of 1996, and they took the patients till February of 2020. The patients that were included there were 129 patients included in this study who presented to the authors with large VSD and pulmonary artery hypertension, which was diagnosed by echocardiogram. All these patients underwent cardiac catheterization. All these patients, none of the patients who presented with them during this period was denied surgery. The information that was collected included the demographics, the echocardiographic data, the cardiac catheterization data, the operative data, the ICU and discharge results. There was a follow-up which was performed on all these patients. The follow-up included early post-operative follow-up, which then went on for a follow-up of at every 3 to 4 months for the first year, and thereafter, if the patient did not have any problems, the follow-up happened annually. So all these patients, the 129 patients, were divided into two groups. The first group of the patients underwent the traditional single patch closure of the VSDs, while the second group of the patients were the patients who underwent the double patch or the unilateral flow technique that was described. It is also to be noted that during from May 1996 till 2005, none of the patients received sildenafil, while from 2005 onwards, all the patients who presented to them with elevated pulmonary with eliminated pulmonary artery pressures were all given sildenafil at the dose of 3 milligrams per kilogram per day for a period of 3 months prior to them undergoing cardiac catheterization. So while doing the cardiac catheterization, all of these patients underwent the cardiac catheterization procedure under conscious sedation. There was a baseline hemodynamic study that was performed, which was followed by acute vasoactive testing, which was performed by giving these patients 100% oxygen for about 15 minutes of time. After which the catheterization results were repeated. The definitions, the pulmonary artery hypertension was defined as systolic pulmonary artery pressure to systemic artery pressure of, so they were divided into three groups. So the patients who had systemic pulmonary artery pressure to systolic pulmonary artery pressure to systemic artery pressures of less than 0.4, these patients were defined as having no PAH. The second
We lost your audio.
0.5, these patients were termed to be mildly hypertensive, and the patients who had this ratio above 0.5 but less than 0.7 were termed to be moderately hypertensive, while the patients who had this ratio about 0.7 were termed as patients having severe pulmonary artery hypertension. The decision to use whether the patient will undergo the traditional single patch technique or the double patch technique was made by the local surgeon and the cardiologist for each patient. So this is a flow chart of the treatment that for the treatment of all the 129 patients that were there. So prior to 2005, none of the patients had received sildenafil, and the number of patients was 82. And after 2005, 47 patients were recruited for the study, in which of which all of them received sildenafil at 3 milligrams per kilogram per day for 3 months prior to surgery. Of the 82 patients who underwent surgery prior to 2005, traditional single patch technique was used in 56 patients, while the double patch technique was used in 26 patients, while in the patients in whom sildenafil was used, single patch technique was used in 33 patients, while double patch technique was used in 14 patients. Anesthesia, all the patients after induction received who were induced and intubated for the surgery received 100% oxygen with mild hyperventilation. And after 2005, when they started giving sildenafil, 3 milligrams per kilogram of sildenafil was also given via nasogastric tube. This was to offset any decrease in plasma levels as a result of hemodilution from the CPB. Bypass was usually instituted using the routine aortic bicaval cannulation. Temperature was usually a surgeon's preference, and the temperature ranged from 28 to 34 degrees. The arrest of the heart was accomplished using cold crystalloid cardioplegia at the doses of 30 milligrams per kilograms and was repeated as necessary. So this is the double patch. The double patch that is described. Below the picture is the referral link for the complete methodology of how this patch is prepared. For the sake of completion, what I'm going to do is I'm going to describe in short what this patch usually consists of. And this double patch is constructed with a fenestration. The base patch is constructed with a fenestration. This fenestration is 50% of the size of the Z value of the aortic valve annulus. Over this fenestration, a flap valve patch is fixed. This flap valve patch is measured to be about 3 to 4 millimeters wider in diameter than the fenestration. When this patch is used to repair the VSD, whenever the right ventricular pressures, whether it be the systolic or the diastolic pressure, exceeds the left ventricular pressure or the pulmonary hypertensive crisis occurred, this flap valve opened and the blood started shunting from right to left. And when the left ventricular pressure was higher than the right ventricular pressure, the patch closed, and there will be no VSD that will remain. Also, prior to cross clamp removal, during the surgery, prior to cross clamp removal, a pulmonary artery catheter was inserted percutaneously via the right atrium in all these patients. All the patients were weaned from bypass following institution of inotropic and vasodilator medications, and all the patients were transported to the ICU using moderate hyperventilation with high flow oxygen. It is also to be noted that none of these patients received any intraoperative echo. In the ICU, all the patients were allowed to awaken from the anesthesia. Only those patients who developed pulmonary hypertensive crisis remained intubated. And even then, the only patients who had hemodynamic compromise were the patients who were kept intubated. Pulmonary artery hypertension without any compromise of hemodynamics was not considered to be an indication for continued intubation. All the patients who were on sildenafil were restarted on preoperative sildenafil dose post-operatively. Inotropic medications and vasoactive inotropic drugs were all weaned as was indicated. Echocardiographic data was used in conjunction with the pulmonary artery pressures that were taken by PA lines. And along with the peripheral saturation to assess for the pulmonary hypertensive crisis. The PA catheter was usually removed on the morning of the ICU discharge. Any patient who sildenafil was continued upon ICU discharge only if the PA pressures were elevated. They defined this PA pressure to be elevated if the PA pressure was greater than 40% of the systemic pressure, and was continued till the first post-operative visit, where they again assess these patients for elevated pressures. And this drug, the sildenafil, was continued only if the PA pressures remained high. The moment the pressures came down, they were below 40%, the sildenafil was discontinued. At the follow-up, routine chest X-ray, oxygen saturation, blood work, echocardiogram, and review of the medication and activity levels were assessed. And as I mentioned, if the PA systolic pressures fell below 40% of the systemic value on calculation through echo, the sildenafil was discontinued. Coming to the results, a total of 129 patients were identified in the database, of which, as I mentioned earlier, 40 patients received the double patch technique, while 89 patients received the traditional single patch technique. Of the 129 children, 66 were male children and 63 were female. The median age group which underwent the double patch technique repair was higher than the age group that underwent the traditional single patch technique. And as you can see, the age group that underwent the median age for the children who underwent the double patch closure was 7.5 years as compared to 2.6 years in the traditional single patch technique. Similarly, the weight obviously is also the patients who underwent the double patch VSD closure were heavier, and they weighed around 20 kilograms median as compared to the 11.5 kilograms median in the patients who underwent the traditional single patch technique. The symptoms which were of significance was a cyanosis at the cyanosis with the physical activity. So as you can see in this chart, in this slide, that 23 patients of the 40 patients who underwent double patch closure had cyanosis at physical activity, as compared to 33 patients of 89 patients who had undergone traditional single patch technique. The second thing was the resting saturation less than 90%. So 33% of the patients of the patients who received double patch technique had saturations less than 90% at rest, as compared to the 13.5% patients who had saturations below 90% in the patients who underwent traditional single patch technique. And the third significant difference was found in the hemoglobin levels. So the next two slides are the catheterization data that was seen. I'm just going to summarize the data. So the baseline and the acute vasoactive testing catheterization was done in all the patients, and they were divided, and they have been presented in this table, divided by the operative group and use or non-use of sildenafil. So the patients who underwent the single patch technique correction showed significant differences following the AVT catheterization in systolic pulmonary artery pressures. The systolic pulmonary artery pressure to systemic arterial pressure ratio, and the percentage change in the systolic pulmonary artery pressures. Whereas the single patch techniques subgroups at baseline catheterizations, a significant difference between the subgroups of systemic pulmonary artery pressures to systemic arterial pressures, and QP by QS and OT saturations were found. The percentage of patients with bidirectional shunting approached significance in the traditional single patch technique receiving sildenafil. However, it was not significant. So it just approached, but it did not attain the significance. In the dual patch subgroups, following the AVT catheterization, there was a difference only in QP by QS. The baseline catheterization for the dual patch group showed differences between the sildenafil and non-sildenafil groups in systolic pulmonary artery pressures, systolic pulmonary artery pressures to systolic systemic artery pressure ratio, and pulmonary flows to the systemic flows. Percentage of the patients with QP by QS less than 1.5, oxygen saturation, and number of patients with the O2 saturation less than 90%. As far as the operative data is concerned, there was no significant difference between the two groups with the single patch technique patients with the double patch. There was no difference in the CPB times, with the single patch group having a time of 78 minutes as compared to the double patch group of which had a CPB time of 77 minutes, or the cross clamp time which was 42 minutes versus the 45 minutes between the two groups. The systemic arterial pressure, the systemic pulmonary arterial pressures was also insignificant. post-operatively at the end of the operation in these two groups, with mean of 40 versus 38 in these two groups, and the systemic pulmonary artery pressures to the systemic systolic systemic arterial pressures ratio was also insignificant, with them being 0.42 versus 0.41 at the end of at the end of the operation. So 7 of the 40 patients in the 7 of the 40 patients in the double patch technique, and 5 of the 89 patients who underwent the traditional single patch technique at the end of the operation left the OR with systolic pulmonary artery pressures to systolic systemic artery pressure ratio of greater than 0.7. Mechanical ventilation time and the percentage of patients requiring more than 24 hours of ventilation was less in the double patch group as compared to the single patch group. And even in the double patch group, the patients who had received sildenafil had a significantly shorter times of shorter ventilation times as compared to the patients who did not receive the drug. So the risk factors were calculated, and it was found that the risk factors for mechanical ventilation time and the percentage of the patients requiring more than 24 hours of ventilation were single patch technique, the traditional single patch repair, and presence of a bidirectional shunt on baseline catheterization. So as mentioned previously, the patients who had pulmonary artery hypertension in the ICU, but if this pulmonary artery hypertension was not associated with hemodynamic compromise, extubation was not delayed. Of the patients who had left, so of the 12 patients who had left the OT with the systolic pulmonary artery pressures to systemic artery pressures greater than 0.7, 2 patients had reduction in this ratio in the ICU. And there was no significant difference between the two operative groups as far as the number and type of complications are concerned. Post-operative pulmonary hypertensive crisis occurred in 7 patients of the 40 patients who underwent the double patch technique, while the same complication occurred in 12 of the 89 patients who underwent the traditional single patch technique. However, the point to be noted is that of the 12 patients who suffered the complication, 9 succumbed to it in the traditional single patch group, while only 1 patient who had the pulmonary hypertensive crisis in the patients who had the double patch technique succumbed to it. Mortality was less as we can appreciate in the double patch patients. Just one patient out of the 40 patients succumbed at 2.5%, as compared to the traditional single patch technique, where 9 of the 89 patients died at 10.1%. However, this difference was not significant. So the results of both the traditional patch subgroups were also compared to reveal that the total ventilation time and the number of patients requiring ventilation for more than 24 hours were significantly lower in patients who received sildenafil as compared to the patients who did not receive sildenafil. During the follow-up period, 3 of the patients who underwent single patch closure and 1 patient who underwent double patch closure were lost to follow-up. In addition, 4 patients who underwent single patch repair suffered late deaths, while only 1 patient with a double patch technique died in that group. The age at the last follow-up was significantly different, as the DP group was a median of 9.1 years older than the single patch technique, with P approaching 0.001. The length of follow-up was also different, with the double patch group having 4.5 years of more of the follow-up. The degree of pulmonary artery hypertension at the last follow-up was also dependent on the group and was variable. It was found, and that table has been included in this slide. And the flap wall was functional in the last follow-up in 3/7 of all the patients who had severe PAH. So 3 out of the 7 patients who had severe PAH in the double patch technique, the flap wall was functional. So multivariable logistic regression was used to determine predictors of early death, to predict the in-hospital death factors, and the late death, and the risk factors for the late death as well. And it was found that the use of traditional single patch technique, baseline saturation less than 92%, and PVR to SVR ratio of greater than 0.7 were all significant risk factors for death during the early postoperative period. While for the late postoperative period, the PVR to SVR ratio of greater than 0.6 was the only risk factor that was found to be significant. So based on these results, the authors concluded that the double patch technique is a low risk procedure, and it is very prudent to consider the double patch technique in high risk population, in high risk patients who have elevated pulmonary vascular resistance and have pulmonary arterial hypertension over the traditional single patch repair. And if especially if the PVR to SVR ratio is greater than 0.6, the survival with the DP, the double patch technique is better. So and therefore it is quite prudent to use this technique. The double patch procedure and the sildenafil pretreatment optimizes the post-operative ICU management by reducing the time on the ventilators. If a traditional single patch technique is to be considered, pre-operative sildenafil priming will also shorten the time on the ventilator. The double patch technique also reduces the risk of the death in the event of pulmonary hypertensive crisis. And therefore, this should be considered in all the patients with patients who have severe pulmonary artery hypertension. Moreover, the authors have questioned the age-old prudence of not operating upon the patients who have pulmonary vascular resistance more than 6 Wood units, and an increase and a decrease in the pulmonary artery hypertension less than 20% as a criteria for operating on the patients. As far as the limitations of the study is concerned, this study is a single center study. The sample size is pretty small. This is a non-randomized study. It is also to be noted that there was no strict protocol for using the techniques. So it was just up to the surgeon and the cardiologist to decide which technique they wanted to use based upon the catheterization results. They have also noted that in all these patients, they could not use the nitric oxide, which may have influenced patient categorization. They note that all the patients that they treated had some degree of reversibility, and maybe the presence of nitric oxide would have influenced the magnitude of the change that they had observed. With that, I close my presentation. Thank you very much for listening to me.
Thank you.
very good presented the paper, and the paper is really very interesting. Dr. Novit, if you want to start from now, we would love to listen what you have to tell us about it.
Sure, I would. Can you hear me?
Yes.
Yes, we can.
Okay. All right. Well, listen, first of all, it's a real honor to participate in the Gary Webb Journal Club. Dr. Webb was an icon for all of us, and I just want to express my appreciation to the CHIP Network and the Congenital Heart Academy for allowing me this opportunity to discuss what work that we've been doing for many years. Grace, can I share my screen?
Yes, please.
Okay, so you see that?
Yes.
Yeah, you see that young lady standing next to that fairly elderly heart surgeon?
Yes, we can see very well.
Okay, this is the first double patch done in May of 1996 at the Amosov National Cardiac Surgical Center in Kyiv, Ukraine. This photograph was taken at her 20-year follow-up in May of 2016. Her PA pressure, systolic PA pressure, as estimated by tricuspid regurgitant jet that day, was 35. She did not undergo a catheterization. She is not on sildenafil. She's living a normal life. So, this is, for me, this is sort of the essence of why we do this. I see that I'd like to answer Vitha Kumar's questions. The double patch was not prepared before going on bypass. And I think that I would say that the reason for that was that the surgeons weren't necessarily completely confidential in the measurement of the size of the VSD. So they decided they would take their internal measurements and then prepare it. We do have a video that is going to be in the online version of the manuscript when it finally comes out that shows a functional double patch during a pulmonary hypertensive crisis in the ICU. Let me talk a little bit about your next question, which was, what about echo results from left ventricular outflow tract obstruction? So, we started this in Kyiv in '96. In 1998, we were asked to go to Minsk, and they had a number of kids with severe pulmonary hypertension and elevated PVR as well. And we, took them through the technique on 3 or 4 kids on that trip. And then they started doing it on their own. But they made a critical technical change. Instead of orienting the patch so that it opens out towards the apex of the LV, they oriented the patch so that it opened towards the aortic valve. They had a child that had ultra severe pulmonary hypertensive crisis. The flap valve may have been too big. I don't really know, but I can tell you that it caused significant left ventricular outflow tract obstruction in that child with a echo gradient of 55, and that child actually died. They never put the patch in that direction again. Mean age in your study of PP less that translate to less PH crisis in the group. I'm not sure I understand that last question. So, Vitamor, perhaps you could, are you still with us? Maybe you could ask that question out loud. No? Or maybe somebody could translate that note. I'm not sure I know how to answer that question. At any rate, we've used this technique all over the world. The reason that we stuck with the study group at Amosov is that when we set this program up, that young lady, that you saw had actually been denied surgery in '95. We made our first visit in '94. They told us about the problem. I jumped into the literature during '95 to research what we were going to do. And then we did the first in '96. But that young lady was cathed in 95 and was denied surgery. When we came back in 96 and I told them we'd come up with a method to do this, that's when we did her operation. And obviously she's done quite well with it. They set up in 96 a study group and an isolated database for all these patients. So we have actually I think, superb follow-up, with the exception of losing a couple patients to late follow-up. We found almost literally all these patients that have not died. Some people ask us, how do you keep up with these patients after, 15, 18, 20, 22 years? I mean, we have follow-up now out to almost 23 years on a number of these patients. And the way that we initiated follow-up, if they had stopped making their annual visits, was, get ready, online social media. We had names, obviously. We had first names, we had surnames, we had cities. So we targeted them through social media. And the response was fantastic. So there are a lot of bad things about social media, but being able to find your patients later in life is one of the benefits to this. So this group was a group that had really fantastic follow-up by the Amosov Center. We had a fantastic response from the patients who all came back. All the survivors and those that lost to follow-up came back during our 4-month follow-up study period. So, we don't have data like that for any of our other sites where we have done this. We have probably 35 or 40 double patch patients in Rawalpindi, in Pakistan, from the Armed Forces Institute of Cardiology. We published a paper on the effect of sildenafil in those kids. We probably have 75 or 80 throughout the regions of Iraq, running from Suli, Manaya, all the way down to Basra. We have a number in China, etc. But the follow-up in all of these countries, and I tried to do this back in 2017, the follow-up in all these countries, as compared to Amosov, is, in my opinion, was inadequate in order to take all 252 patients at that time that we had and do follow-up on them. Now, let me highlight a couple things, and Sharmil, don't get upset with me. I just want to make a little correction with you here. We didn't publish our initial results in 95. We published our initial results in 98, the first 18 patients we'd operated on. And it was a heterogeneous group. There was a transpo VSD in that group who was 9 years old. There were a few AV canals, a couple of interrupted arch VSDs. A very heterogeneous group. We published a follow-up paper, which we actually were happy to get the follow-up that we did in 2005 in the Annals of Thoracic Surgery. And we stumbled across a very interesting finding, and that was that the mortality for our simple group of double patch patients. Now, understand, this is prior to the use of sildenafil. That study follow-up period closed out in 2004. But in the double patch VSD, whether it was multiple, with ASD, with PDA, whatever, was about 3.6%. Mortality rate in the complex group, which included, canals, transpose, interrupted aortic arches, you name it, was 16%. And when we further broke that down, we found that the biggest problem was in the AV canal group. And so in 2004, we ceased putting double patches in AV canal kids. I don't know if it was our technique. I don't know if I was too slow. I'm not sure what it was, but our attitude has been now to ban the canals first and bring them back later and recheck them and see if their PVR has dropped. I'm not sure if that's right or wrong. We are now placing all patients that we meet that have echo proven serious pulmonary artery hypertension on sildenafil prior to their baseline catheterization and acute vasoactive testing, which is usually done either on admission for surgery or slightly before, a week, 10 days before the surgical procedure is scheduled. I do not remember a death in the double patch group since we have instituted this philosophy, with the exception of the one child that died in Kyiv, who was a double patch, who did get sildenafil, who died of hypoxia and pulmonary hypertensive crisis secondary to developing a nosocomial pneumonia. And I can tell you that any patients, at least in our experience around the world, any patient that develops any type of respiratory infection and or significant atelectasis, which causes profound pulmonary hypertensive crisis, this is a really bad group to have to deal with. And they all end up staying on the ventilator for quite a while under intensive therapy, much like you would treat a traditional patch who develops pulmonary hypertensive crisis postoperatively. So I'm free to answer any questions that anybody would ask if they would like a little bit more information. Let me just add one last piece. In the double patch group, as you saw, the long-term survival was calculated based upon the last follow-up, which was provided between October of 19 and February of 20. Unfortunately, we do have another death in the double patch group, which occurred last year. Was one of our long-term survivors who had initially moderate pulmonary hypertension, and then at about post-operative year 12, she was initially a non-sildenafil patient. At post-operative year 12, she was placed on sildenafil for near systemic pulmonary artery pressures, and quite frankly, she did reasonably well. Her double patch was working, but she died of COVID in April of 2021. But she's not actually included in the long-term data. We have another paper that we're putting together for circulation, and her death obviously will be included in the long-term follow-up in that manuscript. So, let's see, we have online questions. Let me see if I can answer any.
Dr. Novick, if it's okay with you, we can go to the panelists and then why
Sure.
people please type your questions in the QA chat box, and then we go back to the questions
after
we have the discussion with the panelists. How does it feel like? Is that okay?
Yeah.
Yeah, that sounds perfect.
Perfect. If you can start with Dr. Berger, who has a massive experience with pulmonary hypertension, we really like to see your thoughts about this topic, Dr. Berger. Thank you for joining us today.
Well, I think thank you for allowing me to participate on the panel. Really appreciate that. And first of all, congratulations to this group for putting together such a wonderful database. It is an amazing amount of data for long-term follow-up. It's truly remarkable. I think that to me, the most interesting group here is the 20 patients who had pulmonary vascular resistance to systemic vascular resistance ratio greater than 0.67. And you look at the Kaplan-Meier curve, how well the double patch group does compared to the traditional group. I think this is certainly a technique that extends the limits of operability. I also wonder what the influence of age is. As lung growth continues into you're about 6 or 7 years, finding these kids when they're 5 may have a markedly different outcome than if they're 12 or 15. Appreciate Dr. Novak commenting on that particular aspect.
Stuart, we agree with you. There was a paper written by Dr. Zhang in 1995 or 96, published in the Annals, that published their first group of double flap valve patches. Some were ASDs, some were VSDs, and they were all excited about this technique. And, you know, there's a lot of people in China. And a couple of years later, they published another paper, and they were still very excited about it. And then in 2000, I want to say 19, in the Journal of Cardiovascular and Thoracic Surgery, they published their long-term follow-up and their early mortality data. And their patients were considerably older than our patients. I mean, we're talking about a mean age, or I can't remember if it was mean or median, but they were not even adolescents anymore. I mean, these were young adults, mostly, that they were operating on. And they did not find any difference, which I found fascinating. And this was strictly VSDs, no complex stuff. They found no difference in mortality that was significant. I think their double patch patients had a mortality around 5.5%, and their single patch patients around 6.6% or something like that. But, you know, I mean, 7 years old versus, I don't know, let's take a guess and say a mean of age of 20 for theirs. You know, we had one mortality with 2.5%, and they had several with 5.5%. So I do think there will be an age differential. Our data in Iraq, if I could ever get long-term follow-up on it, I think would display that problem. We have a number of much older children in the Iraqi group. We're back in Iraq now, and we're trying to do follow-up on all these kids, but we're in Basra, which is, as you probably know, is way down in the south. And trying to get all these kids to come down to see us has been problematic so far. So I agree with you. I think age could be a risk factor for survival.
Bill, can I follow up John's question really quick on that? You talked about age in one direction, and I think what I heard you asking, John, was is there a difference between 7 or 8 when the lung is completely grown, basically, and 3 or 4? Do you think that we're going to be able to have a much better result because by your technique, we'll be able to cut that flow and pressure down early and get new alveoli and pulmonary vasculature to grow normally?
Yeah, I think that's a reasonable question, Gil. And I'm sorry I misunderstood Dr. Berger's question. But you know, you can look at that data from the traditional patch group. I mean, these kids were, you know, 2+ years old, and they had a mortality rate of, you know, 10% or nearly 10.9%. They should have had double patches. I don't think there's any question about that. So my answer is yes. I think if it's done earlier, you could certainly decrease a number of things. One, or early mortality rate in kids with pulmonary hypertension, elevated pulmonary vascular resistance. 2, you could probably speed them through the ICU even more quickly. I mean, our kids in the double patch group got out of the ICU pretty fast. Yeah, I think if you could put the double patch in earlier. So what we have done now is that any child that is over 2 years of age with pulmonary hypertension by echo, we put on sildenafil and bring them back actually more frequently than we did in Kyiv. In Kyiv, we put them on the sildenafil, and you know, they would have an appointment date for a cath 2.5 or 3 months later, and nobody would see them in between. What we're doing now is we're putting these kids on sildenafil, and we're having them come for follow-up with a local pediatric cardiologist to do 2 things. One, what's their resting saturation on sildenafil? And number 2, what's their exercise saturation on sildenafil as compared to what it was, you know, before we put them on sildenafil. So, you know, that group for us now, we have lowered our age parameter to that. Now, let me throw a caveat in. If it's a Down syndrome baby, then we're looking back actually at 18 months on these kids. I'm not sure that's far enough back. Maybe we should lower it to 12 months. And I am all up for suggestions and advice on this because, this is a complicated group of kids, and complicated in terms of their outcomes if you don't fix them. Obviously, getting all these kids operated on, prior to 1 year of age would be fantastic. But that's not realistic in low and middle income countries. There are multiple reasons for that. It's not just because they're not diagnosed.
This is true.
Thanks,
And
Bill.
I think you have a lot of people from these countries on the panel today, and I'd love to listen to their experience. Dr. Vivian is from Tanzania. So what is your experience, Vivi, with these patients? How do they present to you, and what's the management on your country?
Thank you very much for such a wonderful presentation. And this is really important in our setup, coming from low and middle income countries. I would say majority of our patients are these type of patients. When he talked about late referral, which is coupled by a number of reasons, not only being misdiagnosed. Some of them, most of them are misdiagnosed, treated for pneumonia, for TB for a while, but the majority of them not having access to healthcare or not having financial constraints to actually get it fixed early. So this is actually a very huge group of patients that we see. I would say 3 years before, most of these patients were just deemed inoperable, and they would just get scheduled for palliative medical treatment. And then eventually we started doing early sildenafil, but then we would do sildenafil at the end of surgery. And this gave us still a lot of pulmonary hypertensive crisis in ICU. And the only rescue we had was oxygen and the oral sildenafil, with no access to an O, with no access to ECMO, with no access to a lot of medical supportive therapies. This gave us a lot of mortality, as well as a lot of time in intubated, time in ICU, time in hospital. And currently, we started using sildenafil early. So these kids, about 2 years, 1 year ago, when they go to cath lab and we see their pulmonary vascular resistance is very high and maybe mildly or moderately responsive to oxygen, we would keep them on sildenafil for a week to 4 weeks while we're observing them in the hospital, and then they will get scheduled for surgery. But also we had a problem with this. This is one of the questions I wanted to ask. So when you're talking about age, so we would see majority of our kids around 2-3 years, but we have a lot of 5, 7 to 15 years with VSD and severe pulmonary hypertension. So when we started this preoperative sildenafil, we struggled with a few kids where just 1 week on sildenafil, they would flood their lungs. And when they go to surgery, this gave us a lot of trouble in ICU. And this is what I wanted to ask. Did you see this in your type of patients? How frequent did you follow up? Because these kids actually didn't even go home. We had them in the hospital. I think 2 of the kids had just 2 weeks of sildenafil, and they were flooded really badly. So in your experience, is this something you see, and how do you?
Yeah,
Bill, before you answer that, I just am ignorant of the geography, Vivian. What's the altitude in Tanzania? Does that contribute to this at all?
No, we are below equator, sub-Saharan, and where I work, it's at the sea level, so there's no altitude at all.
Thanks. Okay, Bill, I need to be sure I wasn't missing anything.
No, that's okay. It's all right, Gil. Vivian, are you from Dar es Salaam?
So I'm from Dar es Salaam.
Yeah. So I'm pretty familiar with your program, even though you and I have never met. So we did not see this because I think that all of the cardiologists that we dealt with, at least in Kiev, were cognizant of this possibility. This was a conversation that we had in advance of starting any of this. So even though the patients didn't come back at that time, every one of the patients had their anticongestive medicines upped at the time that the sildenafil was started. We didn't have a postoperative problem with regards to flooding their lungs. And this is one of the things that we tell all of the parents that we're dealing with now, especially if they're under 4 years of age. That's the group, the double patch kids that were in the original group, not a single one of those kids had a problem. There is, as you saw from the data, there is a improvement in QPQS, but it wasn't monumental. I mean, QPQS went up, but we're not talking about 5 to 1 or 6 to 1. And I think that's what you're seeing in some of those children that you're talking about that flooded their lungs. So everybody's counseled. Most all of the cardiologists that are dealing with kids that are under the age of 4 increase their anticongestive therapy. Captopril is increased, their furosemide. We may even add spironolactone to some of those kids, or hydrochlorothiazide. So we're cognizant of this problem, but we've been careful to address it prior to starting the sildenafil. Now, can I ask you a question, Vivian?
Yes.
So you talked about, your early mortality was pretty high, and then you put these kids on sildenafil. Have you seen a decrease in your mortality rate now?
Yeah, so for the past 2 years, we have no mortality in these kids, no mortality at all. We had maybe 2, but then this was in a complex. It was not just VSD, it was a VSD with PDA and some LVOT obstruction. But for those with just pure VSDs or VSD and PDA, we have no mortality for 2 years now. And this is since we started this early sildenafil or really frequent sildenafil after surgery.
Well, see, now if you have adequate historical data, you've got enough information there to put yourself together a manuscript and let everybody in the world know how well this works. I know this is controversial. I understand that. But I think that you're finding that more and more people, Iran, we have colleagues in Iran that are doing this. We have colleagues, Gil, in Bogota that are doing this. Nestor does this.
And that is altitude complicated as well.
Oh, yes. Oh, yes, it is.
Actually, now the cath lab group, I was just talking to them a few days back. They've had like a database. They have patients that when they do cath lab and they have pulmonary vascular resistance Wood unit more than 6, they've kept them for sildenafil and follow them up for like 6 to 1 year. And I think the first batch will be scheduled in 1 month time to come for their reevaluation. And these are the patients that they've been following up, and possibly we can get quite a nice study from these results.
Right. Well, just think about it,
No, it's a very interesting experience, Vivi. Dr. Berger has something to say, and after that, I want to listen to the experience from India. Dr. Berger, please.
No, all this makes very sense. Great sense to me. We, in the United States, we have a different issue where we have a lot of ex-premature infants who may or may not also have congenital heart disease. And it is somewhat controversial to start treatment for them prior to their cardiac surgery. But we've had great success with that, managing their pulmonary hypertension prior to surgery. It does take a lot of close follow-up and adjustment, as Dr. Novick said, about diuretics and other anti-congestive therapies. So.
Perfect, makes a lot of sense. This is another population that we need to look at. So Dr. Mishra and Dr. Taylor, if you want to tell us your experience on your center in India.
Yeah, first of all, thanks a lot for involving me as a panelist in such a good topic, which is a very common problem all around the world. As you know, that India is a developing country, and the number of centers where this complex operation performed is very little. So we do get patients very late presenting, sometimes 30 years of age, 35 years of age, large VST, but they are still not Eisenmenger. So we also give sildenafil in such patients, and then we recatheterize them and try to find out what is the cath data, whether it is operable or not. And touch wood, most of them will survive to 30, 35 years age. Most of them are operable. And I had never used this fenestrated double patch technique. We directly close it. A couple of cases I have done where I've fenestrated VSD patch closer is done, and after 6 months or a year, that fenestration was closed. We have never used this double patch technique. What I want to know is what is if the basal saturation is less than 90%, and if you get such patient and you give say sildenafil for 3 months or for the 6 months, what are the percentage of the patient, especially grown-up kids, like say around 15 to 20 years, what percent of the patient will this pulmonary vascular resistance will come down to baseline if you compare with the infants or say 2 years or 3 years old of child? So this is what is the response to sildenafil in younger age group and elderly patient. The other thing, the couple of patients where the pulmonary arterial hypertension is severe and they were borderline operable bidirectional, left atrium and left ventricle was enlarged, and we did it. But now we are in trouble because they have dilatation of the right ventricle and right ventricular dysfunction. So now we have put them on sildenafil and bosentan. This is what we are using. But most of the time we will like to close if they are operable by a cath study, then we would like to close them, and we never come across such problem. But except for a couple of patients, we never had this problem. So we are happy to close them directly, but this technique sounds good and we may be using it sometime. We get a patient with. So I would like to know the opinion of Dr. Novik about the patients who are presenting late, elderly adult patient, and the patients who are presenting 2 years, 3 years. What is the percent of the patient who the cath data will improve and they will be towards the operability response to sildenafil?
So let me ask you a question, Amit, with regards to the nature of your question about the cath data. So what areas are you looking for improvement? Because one of the things that we found was that although we might get a decrease in the peak systolic pulmonary artery pressure, it didn't necessarily correlate to a decrease in the mean pulmonary artery pressure in that group. And that was something that we're looking at more in depth right now. But as you can see, the sildenafil group and the double patch, which is our older group of kids, their QPQS all improved in that sildenafil group. And so we feel that you can improve some of the catheterization data, but not necessarily all of the catheterization data with preoperative administration of sildenafil. Now, with regards to age, I would say if we go back and look at the 9 deaths that occurred in the traditional patch group, these are the youngsters that you're talking about that we have a 2.5 year median age. There were 12 pulmonary hypertensive crises, and there were 8 of the 9 deaths that occurred in children that were not on sildenafil preoperatively. Is that a direct result of sildenafil? I mean, they were all traditional single patch closures. And although the p-value was not significant, we've talked about this a lot because we don't have, I don't think, big enough numbers and long-term follow-up to be able to make a statement about the difference between sildenafil and non-sildenafil patients. Now, let me add just one last little thing. I'm not sure I've adequately answered your question, but we have some much older patients in our Russia group. And I'm talking, like you just said, we've got several patients that are between 29 and 35 years of age. Every one of those patients received sildenafil preoperatively for a 3-month time period. I don't have the data sitting in front of me, but I can just tell you in general, all of those patients are still alive, and they all had what we call severe. Now, we're not using WHO criteria for pulmonary hypertension, as you've seen in the paper, which is a limitation in the study as well, which we should have mentioned, but we didn't. But we're talking about people that all had systemic PA pressures with SATs less than 90 before they were started on their sildenafil. And the Russians do things a little bit differently. They actually cathed everybody, and then we put them on sildenafil. They would not use just an echo diagnosis. Do those patients have severe pulmonary hypertension by our numbers postoperatively? 2 out of, I believe, 7 do have severe pulmonary hypertension. But the other 5, we're looking at mild to moderate by our standards, pulmonary hypertension. So systolic PA pressures that are greater than 40% of systemic, but less than 70% of systemic. You're talking about RV dysfunction, and I certainly agree with that. The recent study on RV dysfunction and pulmonary hypertension using misocetan, I think, is an indicator that the use of endothelin blockers, whether it's misocetan or bosentan or whatever, is highly beneficial in this group of patients. And I think that's something that we should include in our armamentarium if the sildenafil treatment alone is not improving the clinical parameters on the patients.
Yeah, there are some studies from India which say that if the pulmonary vascular resistance is not going less than 0.7 on sildenafil treatment also, then also better to leave them as it is. Otherwise, sooner or later, they are going to suffer with right ventricular problems.
You mean the pulmonary vascular resistance to systemic vascular resistance ratio when you say 0.7?
Yeah.
Yeah,
Yeah, if it is not going, say it's 0.8, we take it to the cutoff that after 0.8, it's not fair to operate then. If you're giving sildenafil, it's not coming to 0.6 or less than that, then whether it is okay to accept them for surgery or it's safe to say, so 0.7 and it's not going down even after sildenafil, whether you will like to take such patients for surgery, high risk surgery, or you will leave them. Because the studies says that you leave them as it is, they will have a better quality of life even if they get Eisenmenger rise, rather than closing the VSD and then getting severe right ventricular dysfunction, pulmonary regurgitation and all that.
one of the things